Good afternoon, everyone, and thank you for being here today with us at the kickoff session of the Vitrolife Group Academy Studio. My name is Nasser Al-Asmar, and I am the Scientific Director of the Genomics Academy. Today, it is my pleasure to introduce you my colleague and friend, Tiffany Stankiewicz, who is going to be hosting the first session that is going to talk about the endometrial, meeting the experts, two key opinion leaders, not only in the US, but worldwide. So Tiffany, please, whenever you want.
Thank you, Nasser. So thank you, Dr. Amy and Dr. Rogers, for being here today. I'm super excited, especially to kick off with you two. We had a webinar back in March, and it was really well received, so we're super happy to do an encore today. And as the title said, we're talking about endometrial analysis. So we know it plays an important role in IVF treatment for patients that optimize outcomes, receptivity, microbiome. So we're just having a nice casual conversation about endometrial testing today. We are live here at ASRM, and we have people walking back and forth the booth. So if there's any questions out in the crowd, feel free to raise your hand and we can discuss it. But I think I want to start today maybe talking about a little bit of a hot topic, which is endometrial receptivity analysis. So we've been hearing a lot about that, whether it's good or bad. But there's been some publications showing, no benefit, but in the good prognosis patients. And I think it's important when we have such personalized tests like endometrial receptivity that we're using it in the indicated population. And I'm just interested to know, how are you using receptivity analysis in your own practice, and in which patients, and maybe give us your opinion on some of the publications that have come out recently. So whoever wants to start.
Maybe I will start. So I think that these studies were really important to help us understand and get a little bit more clarity about data in what populations this test is best for. And I think we were all a little surprised by the data, maybe, that there wasn't, like, in the general population, maybe a higher chance of pregnancy, right? But I still think that there is a very real and necessary population that really benefits from endometrial testing. And personally, I like to use this test in people who failed a PGT-tested embryo. So if you put in a PGT-tested embryo, and I understand the success rates aren't 100%, but really we should be looking for other things, whether it's issues structurally inside the uterus, whether it's microbiome issues, whether it's receptivity issues. I think those are some really important, that's an important group of people who I recommend ERA for. And certainly the other population I still offer to is people with very, very limited embryos, right? Like, I understand recurrent implantation failure. You need to be able to have enough embryos to have recurrent failure. And if you don't have enough embryos, it's something that I offer from the beginning.
Yeah. And I'm all about little sayings like the egg whisperer diet. And I've learned one saying from her, and I actually channel you all the time. And it's diagnosis, prognosis, and treatment. Right? So what are we doing, and why are we doing it? What are your chances, and what are your options? And that treatment options, I think it's really important for us to leave no stone unturned and to offer a patient the menu of options for her to choose from, and we're not choosing for her. So for some patients, for example, I can have a patient that has 10 euploid embryos, and she just really wants to do the test because she wants to leave no stone unturned. And then I have the patient who has, let's say, one normal embryo, and she just doesn't feel like she wants to do the test. But if she does not have a successful transfer, at least she was offered it.
Yep.
Yes.
So that she can't say that she has regret. So we can honestly say we thought about all the options and we made the decision for the choice that was best for us at the time.
And I think that's important, because I think you're probably seeing this trend in your own clinics. Like, we're welcoming a new generation of IVF patients with Gen Z, and they're really well educated on everything they do. I mean, social media has been like a huge catapult for them to learn about any part of their lives.
Right.
So these patients are coming in well informed, and they want to know the options, because they also want autonomy in their care. They want to feel like they're a part of their care, not being told this is what they should do, but being guided of what the options are. So I think, this new generation, we need to kind of change the practice and consider that. So.
Yeah, I mean, I think the one thing that can be really frustrating for a patient out there is that they go to a physician that says that they don't believe in it and it's junk science and you're wasting your time. And I would argue that my implantation rate is almost 80% for those who do the test. So in my hands and in Dr. Rogers' hands, with me performing the test, following a certain protocol and making sure that it's followed perfectly, and I monitor levels before and after. So I feel like in my hands, the test actually performs really well. And maybe in another clinic when there's a whole bunch of doctors and maybe people are just missing important pieces for that, that one big puzzle that they have to put together at the end to design the most beautiful transfer protocol. Maybe they're just missing some of those important pieces and, sometimes starting things a little too late, too early, and not paying attention to the details.
Yeah, exactly. I mean, protocol compliance is absolutely necessary when it comes to ERA because it's such a biologically dependent test. It's not PGTA where we simply get euploid or, abnormal or, we have mosaicism, but it's not as clear as to what we need to do with ERA because we have to depend on, okay, when does progesterone start? Because that's going to affect the reproducibility. So super important. I know that both of you performed the test well and you've been very successful. I've been working with Dr. Rogers for a long time with her cases. And Dr. Amy, you just looked at your clinical outcome, and like you said, you have an 80% implantation rate, which is something that we encourage clinics to do. We have a scientific advisor team who can come out, look at your clinical data, because we also know that we don't always have time to put in all of that and to understand how the test is performing in your hands. But we definitely do see differences between clinics and their outcomes.
Can I ask you a question about your data?
Yeah.
Was that data with like natural cycle, stimulated?
Modified natural, letrozole with estrase only, different types of estradiol, Vibel
And you just
patch.
took all of your ERA cycles?
All of them. Yeah.
That's phenomenal.
Some did Lupron.
80%?
Some did Lupron first.
Wow.
Yeah.
Congratulations.
Like suppression for 1 to 2 months.
That's amazing, right? Yeah, I do with some of that.
Yeah.
Yeah, and it's, especially for patients where, we're reserving this test a lot of times for recurrent implantation failure. These patients have exhausted a lot of other options, and we just want to optimize things as much as possible because as easy as to say, well, just try again, a lot of patients can't just try again, whether it's financially, psychologically, the strain on their relationships with their partners, that all needs to go into consideration.
Yeah. Well, and the other thing is, why would you try again something that didn't work?
Right.
Yeah,
Why would you continue doing something that's not working? I know I always am trying to, if something didn't work, let's not do the, and maybe it was the embryo, but if it's a PGT tested embryo, why are you doing the same thing that didn't work?
We should call it PRIF, Prevent Recurrent Implantation Failure.
I love your acronyms.
that.
They're
That's
amazing.
what I say. I call it the Prevent Recurrent Pregnancy Loss Workup. So before you even have a loss, let's see what we can do to even prevent. If you've had even one, I do, and I'm sure you do too. And that's part of this process is preventing those worst case scenarios that you don't want to live through with patients because we're so emotionally invested.
Yep.
Yeah.
Can I ask you a question just from the iGenomics side? I know that we can run the ERA test in a natural cycle.
Yes.
And I know we can run the test in a hormone replacement cycle. What are the thoughts these days on stimulated cycles, either like a letrozole?
So with stimulated cycles, obviously, we have supraphysiological hormones, and that can affect the reproducibility of the results.
Well, maybe not with letrozole, I guess.
But we're like with gonadotropins if we have
absolutely.
ovarian stimulation. So, we want to ensure as much reproducibility as possible, and that's why we've always said, okay, HRT is going to be your way to go. But natural is certainly acceptable too.
And it just takes a lot more hand-holding.
Yep.
And that's
And
the
maybe
thing.
close
more
monitoring.
visits, more ultrasounds, more blood draws, and that's okay for me because I don't want patients putting stuff in there.
I love natural cycles. I do. I love natural cycles. I do.
Oh,
Hormone
funny.
replacement cycles are great for a lot of reasons, and they're super reproducible. I think that it's nice because patients can schedule exactly when it works for them. I know I'm going to be there, but natural cycles are fantastic. For the right patients, of course.
Oh, of course, absolutely.
And I think we're seeing a trend with that in general with natural cycles, and that's globally. We've been getting more questions about natural cycles. We use ERA. Of course, you can use ERA. That's where it was validated in natural cycles. But there's a lot of data showing that the natural cycles have really good outcomes.
Very good outcomes, and
Absolutely.
that's why one of the reasons. And I think that truly, like I mean, we see these patients on these journeys, and a lot of times by the time they get to a transfer, even if it's their first transfer, right? Maybe they've tried on their own for a long time, then they did something with their OB for a long time, then they did like whatever, Clomid, Letrozole, IUI, IVF, and they did a whole IVF stimulation. And so like by the time they get to transfer, sometimes they're just ready for like
they just want to move
less
forward.
meds, more natural, like
Yeah.
kind of back off a little.
Well, and I'm also curious to see, like, as we said earlier, with the new generation coming in, like we've seen a trend of like Gen Z, like going off birth control and trying more natural methods. So they're much more concerned what's going into their bodies, and I just wonder if this is going to be a trend just relating to the generation coming through now.
Right.
So it's exciting. I mean, I think that's the thing with IVF. We can't just keep doing the same thing that we've been doing. We have to progress.
Right.
And I think we're going there. So personalized medicine is key, not only in IVF, but everywhere else. I mean, we were talking the other day about the microbiome and how important that is, especially at the endometrium, let alone the rest of our body. And I'm just curious, is this something that you're looking a lot in your own practice, or where do you think that's playing a role in endometrial health, or we know in endometrial health, I think there's big things coming with the endometrium. With a recent study about endometriosis and fusobacterium in the endometrium, the potential there.
Yeah.
But in reproduction, we know that, for years, that pathogenic bacteria in the endometrium can lead to poor outcomes. So we see it in chronic endometritis. So I'm just curious what you are doing in your own practice regarding microbiome.
Yeah, you want to take this one first?
Well, I mean, as soon as the Trio test became available, I started adding it on. So it didn't make any sense to me. If you're doing ERA, why not just check another box and do the M and Alice? And I'm just heartbroken for those patients out there who have recurrent implantation issues. No one's a failure in my eyes. Just want you to know that.
I love that.
I don't ever use that word in my practice. It's very triggering for me because my mom said I was never good enough. I'm just kidding. Oh my God. Anyways,
We're going deep today.
So, welcome to my therapy session, everyone. Hi. But my point is that I had a patient had 2 failed transfers. Like, she had tubal factor. Her embryos were gorgeous. And I'm like, this just makes no sense. I had already done ERA on her. And then you guys came out with M and Alice, and I'm like, I don't, like, what else? I've already done all my other voodoo hocus pocus stuff. And I'm like, I'm gonna do this. And she had like 3 or 4 things light up.
Yeah.
And I was like, this is bonkers. Treated it, next transfer,
Pregnant.
And
I
she was
love it.
like ready to
That's
give up.
amazing.
Like you said, strain on the marriage, on the relationship, and like her friend group, and then she had a baby.
I really feel like as fertility doctors, we are problem solvers and not always easy problems, right?
Yeah.
Right? So I
Not
feel
always
like
the same problem.
Oh yeah. No, so think about it. Like most people get pregnant without our help. Great. We're like, we're already dealing with this patient population who are either, with the new definition of infertility, not being able to have a successful pregnancy or not being able to get pregnant, right? And so we're taking this group that's already in this, 15% of the population, and we're having to like figure out what to do with them. And when sort of regular IUIs work or regular IVF cycle doesn't work, this is where like really digging deep and trying to figure out, why is this not working? There's only so much science we have at our fingertips, right? And there's still a certain percentage of patients who we can't figure it out. But I think this is an amazing tool because I absolutely have had patients who should have gotten pregnant like multiple times over with euploid embryos and they're not, and then you do a test like this and not only receptivity, but the Alice and Emma testing, if all it is antibiotics. The thing that I really was shocked about when this test came out, and it's been a couple of years now, right?
Yeah.
2021.
Yep.
One of the things that I was most shocked at is I think that when I was getting regular biopsies back with CD138 and they were coming back positive for chronic endometritis, I typically, like, my go-to is the regular gynecologic antibiotics. Z-Pak, Doxy, cool. The percentage of bacteria that was coming up on this test that was not covered by those 2 drugs, which are the like go-to standards, was so high that I was like probably mistreating so many patients, but we didn't have anything, right? And so now being able to target what bacteria, what antibiotic, And I would love for you to, talk about some of the newer resistant strain testing and stuff like that. I mean, that's like a fantastic. This really allows us to be able to accurately treat patients and improve pregnancy rates.
No, and it's true. We know that, we talked about this the other night, there's a staggering statistic by 2050, as many people will die because of antibiotic-resistant bacteria as cancer. So it's
crazy.
It blows my mind, and I've told everyone the statistic because I believe in responsible antibiotic use. I mean, antibiotics, I'm not obviously against antibiotics. They're one of our biggest tools we have in modern day medicine, but we have to use it properly because they can be really powerful, but when it's used improperly, it can hurt us. And that is the advantage with a molecular platform like Emma and Alice, because it's an objective test where we can see, okay, which bacteria are actually present in the endometrium. And now, so actually starting next month, we've been doing this globally, but in the US, we'll now have the actual antibiotic recommendation put in the result. So we'll say amoxicillin, this many, the dosage 7 days or whatever. So it's a more a direct recommendation, so there's no guessing, okay, here's the bacteria, let me find what antibiotic, and then go over here and figure out the dosage. It's going to be right on the report.
Yeah.
So we're hoping that'll improve clinical outcomes further, because just like the ERA, sometimes that's missed with the targeted approach.
Right.
So super excited about that.
Right.
Me too.
Yeah.
So I don't know if Dr. Amy, with the microbiome, you said you've been using it as soon as ERA comes out.
As soon as it comes out, 100% of patients do it. And I just don't understand. If you're putting patients through a biopsy and you're getting plasma cells, it's the same freaking procedure. Mm-hmm. You just put some of the cells in another tube and you can give patients more information.
Yeah.
Yeah, and a lot of times are you doing both of them at the
so
same time?
For some patients I am. I certainly have another group of patients who, who have maybe had failed implantation, have maybe have untested embryos, just maybe not quite as clear, and I'm doing a hysteroscopy on them. A lot of times, while they're on birth control for their hysteroscopy, and while they're asleep, I will do an Al-Asmar test along with the regular pathology. And because I'm sure you notice, you do a hysteroscopy on someone and then maybe there's some polyps, and you do the sample, and I always have them stain for CD138. I feel like there's always some plasma cells, especially in the setting of polyps. And then the question is well, and I always ask this question, right? Is that infectious? Is that just inflammation from the polyps? And when you have the ability to do Al-Asmar testing, or just Alice alone even for patients, I mean, I think, that is something that is a very easy test you can do while someone's on birth control. They're asleep anyway. So I love doing that. And maybe someone who's not quite ready for a whole ERA cycle.
Yeah. Right.
Because if you're there anyway, it's just like you said, they're asleep, you're doing the biopsy anyway, you might as well.
And there are patients who aren't ready for IVF and they just want to learn more about their uterine environment, and I'll have them come in for the test as well because they're just curious.
Yeah, and it could be as something simple as a pathogenic bacteria that's persisting, leading to the failed implantation. Right. Because we know, especially those difficult ones like Gardnerellas, Streptococcus, Staphylococcus, they're associated with a lot higher or poorer clinical outcome rates. Mm-hmm. Mm-hmm. So it's interesting to think that maybe we can save some patients from undergoing IVF that would just be treated with antibiotic. I mean, we were discussing this morning, they're using antibiotics in targeted therapy in cases with autism, where they found that the symptoms go away with certain antibiotics, that it could be in some cases bacteria induced. And I think when it comes to microbiome, we're going to see this a lot in just general medicine and specifically in reproduction. Even here, walking around ASRM, I saw a couple booths. It's how to optimize your microbiome for reproduction, or optimize your diet, which obviously is going to affect your microbiome. Mm-hmm. So it's, I think, again, we're heading more towards personalization, and this is just one key aspect of it.
Right.
I don't know if we have some people in the audience, if we have any questions. If anyone wants to ask, don't be shy. So I don't know how much time we have.
I think David was going to ask a question about our favorite probiotic. Right, David?
Yeah.
Yeah. Do you have a favorite?
I really struggle. In fact, Amy, we need to put together a product.
100%.
I'm like, I want to create a vaginal probiotic for fertility. So the hard part about vaginal probiotics is that there are so many vaginal probiotics out there that are for recurrent, like bacterial vaginosis, for recurrent yeast infections, and they have a lot of other stuff in it, like boric acid and other things that we don't really want our embryo transfer patients maybe taking. And I also worry about like some of the compounded medicine, right? Like we were talking about the other day, like compounded medication. Well, like that's live bacteria. Is the bacteria alive after it's been like compounded and like melted into like a little, you know, wax, you know, or suppository? Or is the bacteria even alive and doing anything, or have we killed it because with heat or something? You know, I would be really curious to. So this is one of my goals. Is to do some like, you know, product development.
Mine are sex toys.
Oh, okay. That's a little not appropriate.
Oh.
I mean,
yes.
When I'm way older, like Dr. Ruth.
So
that's
how long has the course of antibiotics take per patient? So our recommendations, the max is 7 days. But of course, we're a genetics lab. We're not physicians.
I usually do 7 to 10. Like if you look at like treating endometritis, like active endometritis, like it's 7 to 10 days. So I, like, as much as I don't want patients on antibiotics any longer, I think that some antibiotics just, and some infections that might not have as much blood flow and blood supply, right? We're thinking about like inside the endometrium, as opposed to like, you know, maybe as opposed to like the myometrium, which might have better blood supply, you know, but clearly there's not a ton of data on how long people need to be on exactly what treats it.
Well, I've been offering a lot of patients a second biopsy. I don't know if you started doing that.
Before antibiotics?
After. So I'll treat them, and then it's depending on the case. I mean, if this is a patient who's worked her butt off for like, you know, 6 cycles, 1 euploid, and we find something, then I'll do a second biopsy. And I've had the case where like something else comes up, you know, and it's like, then I start thinking, do you do partner testing?
No, but we were talking about this the other day, right? Like whether it
other
makes sense.
exposures to avoid, like what I just talked about.
Yeah. So, well, right. So,
Literally.
like, so the question is, do you recommend protected intercourse then?
Yeah, I
If
mean,
people have
for those
persistent
types of cases,
chronic endometritis.
Yeah.
If they're getting it sexually.
We get that question a lot. We get, should we treat the male partner? Should they avoid intercourse? And you know, we don't know where the source is coming in each patient. It come from any. I mean, just, you know, diet, hygiene. If they're on antibiotic use, maybe they had a dental procedure. We don't know what's happening.
Right.
But I think it is a good idea to be a little extra cautious before that, you know, before implantation, because we want to ensure an optimal microbiome for that implanting embryo. But the case of the test of cure, anytime we recommend an antibiotic because there's a pathogen present, it's a good idea, especially when we have those complex profiles where maybe a couple bacteria are present. But the other thing is, like you said, maybe something else will pop up new. You know, when we're clearing one pathogen out, then the other pathogen, we think of as an ecosystem, like, oh, I don't have any competition now, now I can grow.
Well, the other thing to think about too is that, I mean, endometrial biopsies are very accurate, and they're very good tools to do a biopsy in a outpatient setting that's pretty minimally invasive. But like when I do my Al-Asmar testing at time of hysteroscopy, I do it first, and then I do the scope, because I don't know like the saline and the who knows. So I always do it first, and when I go in and like, you know, after I've done the biopsy, and then I go look, and it can be certainly a very thorough biopsy when someone's asleep, right? Like, and you can see not every single corner of the endometrium is biopsied, and that's okay. But you could imagine maybe there's different bacteria in different places that just maybe haven't reached that above that threshold to make it, you know, pop up.
And I think, you know, you bring up thresholds. I think that's important too, because the endometrial microbiome doesn't have to be completely absent of pathogens. We've seen, so we actually have reference ranges within our report itself.
I can't not treat it though. I mean, I don't know. Like if you had a pathogenic bacteria that was like below the reference range,
I'll talk to the patient about it and offer treatment.
I don't think I cannot. Like I'm like, these bacteria are not really supposed to be in here.
Yeah. So you want them gone?
Yeah, gone.
Yeah, but I don't think that's a bad thing, right?
I know they're below the reference range. But like, let's say the reference range is like 3.5 or whatever it is.
It's like
You're at
3.49.
Right?
Yeah.
And then, right, but maybe even if it's at 2.5, like it maybe shouldn't be in there. What? Maybe that's the cause.
Yeah.
Well, yeah, and
I still treat it.
Yeah. Same.
yeah, and that's why we leave it to discretion of the physicians, because you guys are the physicians, not us. So we'll get that question too.
But you're right, it's a conversation.
Yeah.
Yeah.
And luckily, like, I
Most
mean,
people would say.
antibiotics in general are not real expensive. They're,
Yeah.
you know, they're real safe. And while there are some risks, it's relatively low.
Well, and the good thing too, you can it doesn't really add on extra time to the patient's treatment, because a lot of times you get your results, maybe the patient started day 1, you can give the antibiotics early in the cycle that you're planning to do the rebiopsy, or even, you know, if
Can you
in
know, like, how
transfer.
long does it? Because we're looking at bacterial DNA, right? How long, if that
We
bacterial
discussed
DNA
this.
is,
You wanted,
right?
you kind of wanted to shed, and
I
you
usually
want to
like
get
to
that
have them
bacterial
like have a
DNA
cycle,
through.
like bleed the
Get it all
bacteria
out.
out, and then with the next cycle, what, like, because I think
I'll put them on birth control pills for like 14 days. And
And
then,
then-
do the second biopsy at that point.
We've been hearing that a lot with the birth control pills.
So they
That's
don't
another
have
nice
to
thing
wait a
with
whole other cycle.
with Emma and Alice. You can do the birth control
Yeah.
pills in the cycle. So which
Yeah.
is you can't do with ERA obviously,
Right.
but for retesting the
Yeah.
birth control pill, and again another affordable option for patients.
yeah.
Right.
The only thing that I struggle a little bit with birth control pills, and I do it all the time still, is just that the lining doesn't get as thick.
Right.
So like, you know, I really like to see when you draw the pipette out, I
see a
usually like to see a
nice,
lice, like,
healthy sample.
right, like 7 to 8 centimeters
Yeah.
of tissue.
Yeah.
I don't know what you usually give.
Yeah, about
7 to 8 centimeters of tissue is what I hope for. And then if I'm putting some into another sample for like
Yeah.
regular path or whatever, even more. And when people are on birth control, I have to sort of
It's a little bit.
stay there a little longer to get more sample out.
Yeah.
So, but I mean, I think it's very convenient for patients.
Yeah, at least there's options.
Yeah.
Right. Right. Right.
So you have another question? Oh, we have a question. Go ahead.
Yes. Is it recommended to test again after you've treated, after you've already been treated?
I think, I think we were able to, talk about that with, especially like Dr. Amy said, sometimes a new bacteria pops up. So
Yeah. One of the questions that I have, and I feel like this is something of like new data that we need to like look at, is how much cycle to cycle variability do most people have in their microbiome, right? So, I mean, obviously pathogenic bacteria is different than, like lactobacillus, that is this like healthy bacteria. But, the question is like, if I'm doing an Alice now, and maybe someone takes a break or whatever, or we put them on Lupron or whatever it may be, in 3 months from now, if they have a healthy endometrium with normal Alice and Emma, do we think that in 3 months it's going to be similar? I'm interested in some of like this longer term data that we just don't have yet.
yeah, and again, with the microbiome, because it's so transient and it can be affected by so many things, like we don't know. Like maybe in one person, the results are consistent 6 months later. Maybe in another person, because they had a surgery or
Or they have PCOS or endometriosis.
yeah,
or both.
it could be affecting their microbiome.
Yeah.
So, for that reason, we always say, okay, if a patient's planning to come through transfer in January,
Right.
don't do Emma and Alice today. Wait till December.
Right.
Well,
So I
probably not.
tell patients 3 months before. So if you want to do a transfer, especially for baby number 2, reach out to me 3 months before, and we'll start planning things. What our transfer prep will look like, the saline sono.
perfect.
We'll review, if we did the trio before, do we want to repeat that again? And we have time to do it. So they stay on their timeline.
Yeah. No, I think that's perfect. Well, I guess we're getting the cue to wrap it up. I wish we can keep talking, because
We could
I
talk
really
forever.
enjoy our
Yes.
conversations and the
Thank you,
insight you guys
Tiffany.
have.
Thank
So
you for all you're doing.
thanks for making this happen. We talked back in March, and we're like, it would be a great idea to do this at ASRM. So I'm so
We're all
happy
there,
we
in
made
person.
it happen. So I would love to make this a tradition.
Yeah, I think so.
And I don't know if I have patients who come to me because their doctors won't do this test.
Yes.
And I'll do it for them and then guide them. And that's okay too. It's like seeing an acupuncturist for fertility guidance. You're not cheating on your doctor. It's not a love affair.
Well, I think that you got to advocate for yourself.
Exactly.
Yeah. Well, thank you so much, and I'm happy that we all got together to kick off our Academy booth session. So thanks for
having
joining
us.
in.
marvelous reality that moves us in as many ways as there are people inhabiting this planet. The more we learn about it, its principles, its patterns, and its codes, the more we value being able to help people who cannot conceive naturally. iGenomics was founded in 2009 to work side by side with clinicians in IVF clinics to bring genomics to assist couples fulfill their dream of bringing healthy babies home. Since then, we have brought to light more than 500 scientific publications on reproductive health and processed millions of samples. At iGenomics, we believe that genetics should be available to everyone because important decisions deserve an accurate and personalized diagnosis. We want to accompany you on this exciting journey of life. iGenomics, with science on your side. This marvelous reality that moves us in as many ways as there are people inhabiting this planet. The more we learn about it, its principles, its patterns, and its codes, the more we value being able to help people who cannot conceive naturally. iGenomics was founded in 2009 to work side by side with clinicians in IVF clinics to bring genomics to assist couples fulfill their dream of bringing healthy babies home. Since then, we have brought to light more than 500 scientific publications on reproductive health and processed millions of samples. At iGenomics, we believe that genetics should be available to everyone because important decisions deserve an accurate and personalized diagnosis. We want to accompany you on this exciting journey of life. iGenomics, with science on your side.
Good afternoon, everyone, and thank you for being here today with us. My name is Nasser Al-Asmar, and I am the Scientific Director of the Genomics Academy. So this is the second session of our Vitrolife Group Academy Studio. So again, thank you for being here. And today, it is my pleasure, and it's an honor to host this session. We're going to talk about the IVF, the future and the present of the IVF. And who better to talk about it than Professor David Gardner and Professor Carlos Simon. So first, let's go to have the perspective from the lab. So Professor Gardner, please.
Okay, thank you very much. Well, I think we're living in really interesting times. I've been doing this, actually 40 years this month I started, and what I've witnessed has been remarkable, but I think we're on the verge of another technological breakthrough. And I think what the impact on the laboratory will be is really streamlining what we do. I mean, really streamlining what we do. And when you look at sort of the engineering feats that have come of age, we've talked about microfluidics for many years, but I think microfluidics is really starting to come of age. Not just because you can, do sperm sorting on it, but because you can actually do diagnostics on those chips as well. So I think we're going to see advances in microfluidics. I know there are commercial products already, but I think there's a lot of research coming and we'll develop on that. I think the next thing we'll see is microfabrication. So instead of making just a dish, we can actually print into dishes at a sub-micron level specific things that we need for tasks for our embryologists. And that microfabrication will also facilitate micro-robotics because it's down at that level of control of the embryo, the egg, the sperm, that you'll really start to see some magic happen. And then, I think, having talked about microperfusion culture for over 30 years, I think now the technology is coming that maybe in the future we could do perfusion. And that would mean not only could you do that for culture, you could perfuse cryoprotectants and get an infinite gradient of cryoprotectants, which should improve vitrification. Biomarkers. With all these technologies and this kind of stuff, we'll be able to take out the media and do those kinds of on-chip analysis. And on top of all of that, we have new microscopies. So now we have, as well as conventional light, we've got fluorescence lifetime imaging and hyperspectral, which gives us an insight into the metabolic state of a cell. Well, that's really cool. And then with optical coherence tomography, when that comes through, we'll be able to visualize the embryos like never before. And then, of course, on top of all of that, we'll have artificial intelligence, not only helping us identify the best sperm, for the robot to pick up to inject into the best egg and assess the embryo development, but artificial intelligence will be running the lab. It'll be giving us real-time feedback. And it's about to happen. And I think that's the really exciting thing from my perspective about streamlining the IVF lab. Technology is now caught up with the visions that we've had for the last 2 or 3 decades. So it's very cool to be an embryologist.
It's really cool.
Yeah.
And actually, are we talking about the future or the present? Because it's already here, right?
Yeah, we're talking about the present going into the future. So absolutely, we're doing a lot of it now. But again, with all these technologies, it's actually getting them all to align with each other. I've never really cared for the term lab in a box, but it's coming in some shape or form. It's going to be scaled down. So our footprint is going to get smaller and smaller and smaller, for sure.
Interesting.
Yeah.
And Carlos, what is your perspective regarding the present and future of the IVF?
My perspective, I think that it's not about the future, it's in the pipeline. So it's not future, it's already in the pipeline. And from my clinical perspective, I think that there are 3 basic elements here. First is the patient. So this should be individualized, precision medicine. We have to get away from day 5, day 6 in general, talking about, so it's from generalized medicine to precision medicine, and this is going to take into account the biology of the patient itself in order to really customize the treatments for her. So this is one thing, which is precision medicine in all reproductive medicine, not only in ovarian stimulation, but rather in everything that we do. The second is the doctors itself. So we have to be aware that we have to embrace what is the science that is coming. And this is very difficult to get out of our comfort zone, which is basically to produce embryos and transfer them back, and then give things that are in the shell. We have to base things on biological plausibility that help us to improve results in our patients. So I think that we need that the young people will embrace science as the way to move from the bench to the bedside things, not just doing statistical analysis, comparing things by things. We have not progressed in the last years because of that. And then the third part will be what to do with the embryos that David is able to give us now in the best scenario. And this will be using precision medicine, is going to take in account first what is the background of the couple, starting from the genetic background. Nowadays it will not be absolutely feasible to transfer embryos without knowing the genetic background of the couple. We can prevent recessive diseases, and in fact, you can be liable if you do not prevent this, if you do not inform to the patient from that. So this is not about to have a pregnancy. At the end, it's about to have a healthy live birth. Yeah. So first, genetic background, and then once the embryo comes, we have to consider also the mother. And in the mother, we have in the uterus, when we transfer the embryos, we can consider nowadays the endometrial microbiome, that we have tests for that. And there are also interventional studies showing what happens if you study the microbiome and treat them accordingly. And then we have endometrial receptivity, applying what is the personalized window of implantation to transfer the embryos. And decidualization is coming next to find out what is the impact on obstetrical outcomes and also maybe in miscarriage of euploid embryos. So all of these things are based in scientific developments, but I think the basis is that we have to individualize treatments, consider the biological plausibility of what we are doing, and consider the patient as the mainstream for that. This is what I...
Thank you. Yeah. Thank you, Carlos. So what I can see is that we are still, unfortunately, far away of the 100% pregnancy rates. And we don't know, in biology, in medicine, doesn't exist 100% or 0%. So we need to combine different things in order to try to achieve the better rates as possible. As you were mentioning, Carlos, the embryo, the endometrium, the mother, the media, the culture, the dishes, the time-lapse devices. Yeah. So I think that it's like you have the different stuff and you have to put it all together in order to try to get better results. Because Carlos, we were discussing like 2 months ago regarding the endometrium, and you were telling, okay, if I have my clinic, I would like to offer up to front the best things that can lead into a pregnancy, right?
Well, the way that we are acting with guidelines is just you have to have a lot of failures in order to do things. And the guidelines doesn't tell us what to do in order to be successful. So another way to plan things is if you can get started with what you think, with biological plausibility that can help, you don't need to have 3 previous failures to really do an endometrial analysis or to analyze chromosomically the embryos. If you believe in what you believe, then you have to be consistent and see what happens. And in fact, 50% of cycles here in USA, they are doing through PGTA. They have the best results. And so we have to consider that you don't need to fail to do things sometimes.
Yeah, we don't know that sometimes the guidelines are a little bit behind, right? So, David, what would you say about it?
Well, I would agree with everything Carlos has said. I'm a great believer in not only the biological plausibility, but the personalized medicine. It's all there. I think it's also, from a laboratory perspective, extracting as much information from the gametes, the egg, and the embryo. There's this whole new area called metaboloepigenetics, whereby it really helps to explain the interaction of cells with their environment. And I actually hold that we will be in a very strong position using a lot of these new technologies, whether it's some form of hyperspectral or FLIM, to analyze the metabolic health of these embryos, which feeds in nicely to all the genetics, because that's the phenotype. So, we can do all the genotyping in the world, but at the end of the day, you want to know the phenotype. So we're getting close over the next few years where personalized medicine, combined with more and more analysis of each embryo, to give us a really reassuring perspective of the health of that embryo, because as we said, it's not just about pregnancies, it's about healthy children, and those children living a long, healthy life. And I think we're converging on that with the things that we've
Absolutely.
Yeah.
And you know, if individualization is the issue, the embryo, if you treat the embryo as a patient, is exactly what David is
That's
mentioning.
what I'm saying. Yeah.
Absolutely. I don't know if there's any question on the audience, because I have, but I would like you to interact. I'm pretty sure that in our YouTube channel and LinkedIn channel, there's a lot of questions. But if there's no questions in here, Carlos, may I ask you to make a question to David regarding something about the laboratory that you want to know, and David can give us his opinion?
You know, David, the only thing that I can say is that, you know, he's the best embryologist that I have ever seen in the world. So it is, and this is 40 years, so we are like twins here, so it's 40 years too. So it is. No, I think that, I mean, you have to tell me this before, come on. What I'm going to ask to David that makes sense. I mean, that's
you are doing some studies with the embryos, right?
Right.
With imaging embryos.
Yeah.
And
No, I think that the question for David is about his main thing now, which is metabolomics. How do you foresee this going? How can we combine metabolomics with genomics?
That is a really fascinating question, and to which there isn't a straightforward answer. We've been doing that in stem cells for a number of years. We've been doing transcriptomics and metabolomics, and yet there is no capacity to actually merge those data sets yet, certainly not for the last few years, and I think that's the challenge, because they're very complex information sets you get, and learning how to interpret it. But I think maybe artificial intelligence will be the way to help us interpret these things, because the metabolic phenotype is incredibly complicated. So I think this is going to be a challenge for the next few years to really understand what is going on. Yeah.
And I have the other question.
Yeah.
Which is, you have seen our cell paper. What do you think that could be the potential to add this embryo imaging on top of what we are having now, which is black and white, to add this fluorescence?
Well, it was like seeing it for the first time. I mean, that paper, everyone read the paper and went, I mean, the imagery is everything. So I think, I'm a great believer in the more tools you can use for the same job, the more complete a picture you get. So with your imagery, we were seeing facets of embryo development we'd never seen before. And specifically, when it came down to the chromosomes being moved around, right? So not only is that of interest, but then you can turn that around and say, so can we optimize our procedures to minimize aberrant behavior that we didn't even know was ongoing, right?
Absolutely.
So that's the significance of the dynamic, to actually get as much information, then feed it back into the system. So
absolutely.
So thank you for your paper, and thank you to Nicholas.
Thank you for your answer.
David, any question to Carlos regarding the clinical perspective?
Yeah, okay.
Now it's you.
I've got a list. So, no, I think it's really fascinating. So how do you as a physician feel we have artificial intelligence creating algorithms to help you select your stimulation and what day to trigger? So Gerard Lederer calls it the end of white coat supremacy. So I like that term. So how do you feel as a physician, knowing that so much information is now going to be pushed your way? Is that a good thing or a threat?
It's a good thing.
Yeah.
I mean, we have to take this as a good thing, because artificial intelligence should help us in any stage of the way, including what I mentioned about the embryo. This can give us a different level of understanding of the embryo, because now it's not black and white. But for ovarian stimulation, it's the same. I mean, we cannot pretend that our eyes will be the best in the universe. Now we have artificial intelligence. Now we have everything that we have around. So we should be flexible. We should embrace the advancements and take the best for us. Otherwise, we will become obsolete. This is no other way around.
So what a conversation, right? I could be here forever. I don't know you. I can see here science, passion, innovation. So everything that we put together in order to help the couples to have the baby. So I think that this is why we are all working in this field, right? So I will ask you just last minute, 2 minutes, take-home message from your side, just to tell the people and spread a little bit the voice, because here it is not only people from the reproductive medicine, but also patients that wants to know more about what are you thinking regarding our field at the present and the near future. So please, if you want to give us a take-home message, David.
Okay, so I think the technology is something to embrace. I think it will improve our success and it should lower the costs to do the job. And that makes IVF more affordable, more available. And I think that's one of the big problems worldwide is the availability. So I think through this, it will become more effective, like I said, more streamlined. And it kind of leveled the playing field a bit because it's become so automated. I think that's tremendously exciting. But to all the embryologists out there, don't worry, you're never going to be out of a job because we need the level of insight that embryologists bring to run labs and to troubleshoot. So there is tremendous growth in this field, but I think to meet the growth and the affordability, we can embrace these technologies over the next few years. So that's my take on this.
Thank you, David. Yeah. Carlos?
My take-home message will be similar in terms that our objective is live birth, healthy live birth at home, with also long-term knowing that it's going to be okay, as far as we know. That the second is we have still a large room for improvement. Our actual results are not good at all, because if we talk about 45–50% in a sunny day, I mean, we can really improve that.
Yeah, but it's better than it used to be. I
well,
mean, let's remember.
Yes.
Remember the days when we used to run down the corridor celebrating we had a pregnancy, never mind a percentage, right? So we put it in context.
Yeah, but and we transfer for embryos. We don't say that anymore. So just the past is gone. So so yes. So but the point that I make is we still have a room for improvement, and this should be done through really science, biological plausibility, and flexibility and open mind, because the doctors, we are not going to be without work either. So it's just a matter to know exactly what to do, and if we are good for the patients, we will be better for us and for the field. So.
Okay, so again, when science meets passion and passion meets innovation, we can do whatever we want, right? So if there's no more questions in here, I would like, yes, please.
Just in terms of site of care, so we see in a lot of other areas of medicine, the site of care moving out of hospital and out of lab and increasingly in the patient's home. How do you see that evolving in the IVF space? So how much more can we do at home for the patient, so to speak? What's your view there?
What can we do for the patients at home? That's,
you mean at home with, sorry, I didn't understand.
Yeah, sorry. So I'll come closer.
Maybe it's me, but.
No. So we increasingly see in other areas of medicine the site of care moving away from the hospital or away from the lab. So more remote treatment pathways. How do you see that evolving in IVF?
It's indeed a very good question. You know, what I would like to see first is that we are more efficient. And once we are more efficient, we can think the way to really, get away from the lab or for more sophisticated. Yeah. But first, we have to be sure that it works. Yeah. And so far, it is not working as we have to offer to our patients. Yeah. Imagine an airline that only delivers 40% of passengers to the final destination. Not on time, to the final destination. Yeah.
So more digitalization, more automation to be able to...
But in answer to the question...
Please, excuse me. Could you join us, please?
I will.
Okay.
I will.
Please. So,
Thanks, Nasser.
Okay. So I don't actually envisage a time when we can be without the lab. So I think remotely, amazing amount of remote testing can be done, which will save all the patients the time and stress of having to come in for those tests. Yes. That's going to be amazing. So, and lots of things that will happen there. But at the end of the day, when we do what we call the magic in the lab, it will be in a lab. Yes. And that's not been protective. It's because it's such a sophisticated environment and it's very expensive to create. Yes. And so you'd want the best possible facility. And so in terms of the patient journey, I think we all aim to make it less stressful. And that includes endless trips, round trips for monitoring. But when it comes to the actual procedure, I can't see a way around that.
Yeah.
Yeah, fully agree. You know, telemedicine is growing.
Yes.
So we can do the ultrasounds even at home.
Yes.
We can do saliva testing,
Yeah.
non-invasive. We can analyze the embryos non-invasively. All of these things, we can test the patient. But at the end of the day, somehow, somewhere, you have to get the oocytes, you
Yes.
have to get the embryos. Be sure that those embryos are high
And
quality
do the
and
transfer.
Yeah.
My question, I suppose, looking at it across healthcare, it's an increasing trend. But also, David, you mentioned accessibility.
Yeah.
And as we increase the accessibility in the ecosystem, I think we have a scalability issue here. If you know, look at the sort of patient pathway, there are still a lot of steps that require a lot of requires a lot of intervention. So I think certainly digital and automation needs to come in order to be able to increase scalability and in turn access.
Yeah.
That's coming in my ignorant eyes from sort of other areas of healthcare.
Absolutely. There is a trend here in this country now that more OBGYN is taking care of reproductive endocrinology. So in order to have in remote places and so on. But telemedicine, I think that this should be the way to really advance.
I think that we have to stop in here, but we can
get a coffee.
We can have a coffee later on. So thank you very much. No problem. No problem. Thank you very much, Professor Garner, Professor Simon. Thank you very much for make the questions. And thank you all for being here today with us again at the Vitrolife Group Academy Studio. Thank you and see you in a few minutes. Bye-bye.
marvelous reality that moves us in as many ways as there are people inhabiting this planet. The more we learn about it, its principles, its patterns, and its codes, the more we value being able to help people who cannot conceive naturally. iGenomics was founded in 2009 to work side by side with clinicians in IVF clinics to bring genomics to assist couples fulfill their dream of bringing healthy babies home. Since then, we have brought to light more than 500 scientific publications on reproductive health and processed millions of samples. At iGenomics, we believe that genetics should be available to everyone because important decisions deserve an accurate and personalized diagnosis. We want to accompany you on this exciting journey of life. iGenomics, with science on your side.
Good afternoon and welcome back to the Vitrolife Group Academy Studio. And now it's my pleasure to introduce you my friend and colleague, Dr. Carmen Rubio, that is going to talk about the non-invasive PGT-A. So Carmen, whenever you want, the floor is yours.
Thank you, Nasser. Hello, everybody. I'm here today just to share with you our last updates about the non-invasive PGT-A that we have at iGenomics, Embrace, and also the experience that we were sharing with our users in the last ASRM meeting, in which we had the first Embrace user meeting with the idea just to share and to put together all the knowledge of the positive experience and the concerns that we should address to have a better test. So in the next minutes, I'm going to cover some of the updates of the Embrace, but also I'm going to bring you the experiences that we were collected from this meeting. So all you know that the non-invasive PGT-A, based in the genetic analysis of the cell-free DNA released in the culture media, is being more and more applied in the clinical settings. The way in which this works is that the embryos start to release small fragments of DNA to the culture media during embryo development, and the amount and the quality of this cell-free DNA is higher when the blastocyst reaches the higher number of cells on day 6. We have done several studies just to validate the clinical utility of this test and also to analyze how reliable is the chromosomal analysis in the culture media compared to the analysis of the trophectoden biopsies, but most importantly, of the inner cell mass that really represents the embryo. So in this slide, you can see the latest results that we have reached in our multi-center study. When we are comparing the results of the inner cell mass with the cell-free DNA, we are reaching a concordance rate of 87%. That is very close to the concordance rate that we have when we compare the inner cell mass with a regular trophectoden biopsy. In this study, and these are unpublished results of our multi-center study, we have been able also to collect the clinical outcomes of more than 300 single embryo transfers, in which in all of them, the transfer was performed according to the result of the trophectoden biopsy. In all of the cases, a euploid embryo from a trophectoden biopsy analysis was transferred, but we also had the results of the culture media. And in those cases in which the culture media was abnormal, despite the trophectoden biopsy was normal, you can see how the miscarriage rate was close to 25% compared to the miscarriage rates when both the trophectoden biopsy and the culture media were euploid. So this is representing us, giving us an idea of the importance of the analysis of the culture media. And these results are very reassuring because we had a previous pilot study in which we published these results again, that when we have an aneuploid culture media, you can have a much higher miscarriage rate. So at the end, a lower ongoing pregnancy rate with aneuploid culture media. With all this knowledge and all this research, we also wanted to understand a little more about the origin of the cell-free DNA in the culture media. For sure, we need to understand the mechanisms given to the result of having this cell-free DNA in the media. So we have done this study in collaboration with Nicolas Plachalas, with Boston IVF, and with Carlos Simon Foundation, and we have been able to start to identify some mechanisms that maybe can explain the results of we are observing the culture media. And the mechanism that is being described in this paper is a new mechanism of nuclear DNA shedding during blastocyst development at the interface state. So more or less, this was the update of the information that we were presenting in the EFRE meeting. This is all the knowledge that we are gaining with our studies, clinical studies, and basic research studies. And now I'm going to put here what we were reviewing and commenting with our customers in the last EFRE. Important points that were addressed by the customers and that we all are aware of is we have to care about contamination in the culture media, external contamination, contamination from the cumulus cells. So a lot of insights from the customers were very well received, adding more knowledge to the protocol and for improvements in the IVF lab. We are going to talk a little about possibilities of doing a very nice culture with embryoscope and allowing us to obtain a very good amount of cell-free DNA. And also the timing for media collection that now is, I think, for most of you is very clear that we need to do this on day 6. And finally, we are observing a trend towards different way of information that the customers want to reserve in our report. So we will review this also in the next slides. Regarding contamination, I have mentioned the two sources of contamination, the cumulus cells and the external contamination. In our routine protocol that many of you know because we have been publishing it and talking a lot about this, we need to do serial washes during the culture of the embryos just to minimize the risk of carrying over DNA from the cumulus cells. Very important day 4 washes just to minimize the possibility of having DNA from previous stages in the day 6. And some of our customers, they were spontaneously adding an extra washing step after the fertilization check, and this group is having really fantastic results. And regarding external contamination, it's very important just that everybody working in the protocol in the lab should be conscious about how to minimize contamination from our skin, our saliva, or from the manipulation in the IVF lab. What about embryoscope? We have a poster that will be presented tomorrow, but we have learned that with embryoscope, we are having very good results with very high concordance with the cell-free DNA and the trophectoden biopsies. Why? It's very clear. It has been shown that the number of cells in the blastocyst increases in the embryoscope. So if we have embryos with higher number of cells, they are going to potentially release higher quantity of cell-free DNA. So it makes a lot of sense to have a fantastic culture system to have blastocysts with higher number of cells. Also, the shape of the wells within is really easy as the possibility of like concentrating the DNA at the very bottom of the well, allowing us for a better collection. So we think that the synergies between embryoscope and the possibility of collecting media with EMBRACE for the analysis are going to be really high. And regarding the reports, that is one of the important points that we were commenting. We are offering the non-invasive PGTA, the EMBRACE, as a test to prioritize embryos for transfer. It's not a dichotomic solution, yes or not. It's a priority. We have a number of embryos, and we can understand the probabilities that they have to correspond to a euploid blastocyst, 81%, 24%. So according to what we call the euploid score, we are ranking the embryos, and you can have the priority, the euploid score, or the detailed results of the chromosomal analysis as in a PGTA. What we are observing is an increasing trend of the users and the customers to have just the information regarding embryo priority as IDA score, just to have the rank, the number, without having all the information, because this is considering this test giving us a prediction value to increase the probability of transferring a euploid embryo that should result in a healthy baby. So this is the trend, moving from a more detailed report to a more simple report that in several countries all around the world is making it more clear for patients and for clinicians. So this was some of the experience I collected, but we are able now to have to show you some of the clinical results that the customers were sharing with us. So these results were presented at ERRE, but Ruber International, comparing the EMBRACE with regular morphology. The EMBRACE is in pink. You can observe in good prognosis patients below 30 years of age, how ongoing pregnancy rate was increased with EMBRACE. In another study, presented in Red Lara this year, again, in a general population, there has been an increase with EMBRACE compared to regular morphology, about 10 percentual points in difference. We are observing differences between 10 to 15% compared to morphology. So some reassuring results from our colleagues. And in the user meeting, we were able to have results from different parts of the world. So this is the results from Professor Chen from Taiwan, very early results in which he was working transferring euploid embryos that had a euploid medium with a really high live birth rate, 40%, compared to when they were transferring blindly aneuploid ones with no pregnancy. And very importantly, this was done in patients of really advanced maternal age. You can see that the mean age was 40 years of age. So it's showing that when you transfer a euploid medium, you really can have very good live birth rate, and when you transfer an aneuploid one, as expected, no good results. This is also the series from Katharina from Austria. They have a small data set of cycles. They are applying EMBRACE for patients of poor prognosis due to the regulation in the country, recurrent miscarriage, recurrent implantation failure, but many times associated with advanced female age, and they are having 45% of cycles with transfer resulting in ongoing pregnancies. Again, very nice experience from Dubai, from Maria Banti. They were applying the test and reviewing the results in patients of advanced maternal age, more than 38 years of age, and they were testing two conditions in the lab that we think this is very interesting too. If you should do assisted hatching when you thaw the embryos, because we are transferring Vitrolife blastocysts. So first, they were using the regular protocol. They were comparing morphology with EMBRACE, and you can see how in EMBRACE the ongoing pregnancy rate was 46% compared to 35%. But then they have advice from other colleagues using EMBRACE, and they were incorporated assisted hatchings before transfer when they thaw the embryos, and they increased pregnancy rates in both embryos with a standard morphological transfer, 40% compared to embrace, 52%. So again, we can see the improvements in clinical pregnancies when they were doing the embrace test in their hands. And important message is also from our colleagues is that they were checking if you choose an embryo in a cohort with the best morphology, imagine that is the one in green, and if they check the results of the embrace, they observe that only in 38% of the cases, the embryo selected according to morphology was chromosomally normal. So that's why morphology is not giving us the clear information about chromosomal status. And finally, this is a center in Poland. These are really higher users, the higher users of embrace that we have. They are more and more substituting PGTA with embrace because of patients demand. Patients go to the clinic asking for embrace. They are having very good blastocyst rates. They were comparing the results of embrace with PGTA. That is another comparison that we think is very important. They have similar blastocyst rates. They have similar clinical pregnancy rates. So embrace is working in their hands very similarly to PGTA, chromosomal analysis of the embryo without a biopsy. So important to put together all the information from our users, from our customers. They are applying in different indications, mostly advanced maternal age combined with other indications, poor prognosis patients, and you can see how the results are really consistent among different customers. So from all this meeting, was a one-day meeting, a lot of information. What we learned is that it was very important to have been very supportive with the clinicians and the embryologists in how to validate the test and how to implement the test in each clinic. The users were really very open to share the information and how they apply the clinical results, the indications, good prognosis patients. In some cases, in clinics in which they are doing PGTA for advanced maternal age, they do embrace for the youngest one. In other clinics, they are doing for patients of poorer prognosis, cases with poor quality blastocysts, and in some clinics for all patients. In general, I think that we can conclude that we can increase the ongoing pregnancy rates by 10 to 15 points compared to morphological embryo selection. And for sure, we need to keep working to improve the test, automated workflows, to try to find a cost-effective system to identify contamination combined with time lapse for sure, and understand how we can help the patients also to understand the results with genetic counseling. And just to end, just some pictures of the event that we were having there with the colleagues and the customers there. Thank you.
Thank you very much, Carmen, for the nice presentation as always. Unfortunately, we took the time for the questions, but please don't be shy and ask Carmen the questions that you want now that we are finishing. So thank you again, Carmen, and thank you all for being here.
Thank you.
Bye.
This marvelous reality that moves us in as many ways as there are people inhabiting this planet. The more we learn about it, its principles, its patterns, and its codes, the more we value being able to help people who cannot conceive naturally. iGenomics was founded in 2009 to work side by side with clinicians in IVF clinics to bring genomics to assist couples fulfill their dream of bringing healthy babies home. Since then, we have brought to light more than 500 scientific publications on reproductive health and processed millions of samples. At iGenomics, we believe that genetics should be available to everyone because important decisions deserve an accurate and personalized diagnosis. We want to accompany you on this exciting journey of life. iGenomics, with science on your side.
Good afternoon again. And well, I don't think that I need to introduce myself because I've been here for the different sessions. So for the sake of time, let's move into the presentation. And I'm going to talk about the non-invasive products of conception to know if the miscarriage happened because of chromosomal abnormality. So we do know that at the medicine field, we are looking for the non-invasiveness. For instance, in oncology field, we are looking at the bloodstream, some biomarkers that can let us know if a person is going to develop or the probability to develop a cancer. And in our field of reproductive medicine, we have the example of the NIPT, the non-invasive prenatal test, where we are looking for the chromosomal status of the embryo in the bloodstream of the mother. And also we have the EMBRACE, the non-invasive PGTA, where in the media, in the culture media, we are looking for the cell-free DNA in order to know the chromosomal status of the embryo. So just as a brief introduction, we do know that the incidence of spontaneous abortions is around 15% in normal population, that most of them, around 80%, occurs in the first trimester of pregnancy, but which could be considered as a biological barrier, and that chromosomal abnormalities are the most frequent cause. Actually, these chromosomal abnormalities or aneuploidies can cause spontaneous abortions and also a baby with a chromosomopathy. We do know that more of 50% of the miscarriages are due to chromosomal abnormalities, and these numbers increase up to 60% when the miscarriage happens in a couple who has undergone assisted reproduction treatment. So in this paper, I would like to emphasize that the authors told us that almost a third of women were not able to collect the true pregnancy tissue, and they were claiming that this is why it's relevant to introduce a pregnancy tissue independent alternative. So now we have the non-invasive POC that basically, just with a blood drawn, we will be able to know the status of the chromosomal on the miscarriage. So then we can do better counseling to the physician, and the physician can be better counseling to the patients. What is the molecular basis of the non-invasive POC? So well, we do know that cell-free fetal DNA is released from the maternal bloodstream in cases of ongoing pregnancies. This is the basis of the non-invasive prenatal test, but also when arrested pregnancies. So we will be able to detect some chromosomal abnormalities or not into the bloodstream. The thing is that we have a clear example at the vanishing twin syndrome, where the sac that is arrested is still releasing some DNA to the bloodstream until a few weeks are passed. So why should we choose the non-invasive POC? First, it's a non-invasive way. So we said just a blood draw, and we will know the chromosomal status of the fetus. And also, sometimes the doctor says, I don't know how to do the hysteroembryoscopy, or I want to avoid any risk derived from an invasive sample, or patient would rather have a private evacuation. So in these cases, we can use the non-invasive POC, but also because it's fast. In only 10 to 7 days, we will have the results. Meanwhile, when you do regular karyotyping, it will take 1 month. And this is the process. Again, it's similar to the NIPT. We do the blood draw extraction before, super important, the POC removal. We do know that once we remove the products of conception, the DNA coming from the fetus is going to be eliminated right away. And then we will process the sample and we will do the cell-free DNA testing. So our experience, we published this paper like 3 months ago. My colleague Nuria Balaguer from the Dr. Miguel Milan department, when we were analyzing the 120 patients, doing a comparison in between the regular POC, when we take the products of conception and do analyze by NGS, and also taking the blood and doing the non-invasive POC. So the conclusions were that that we found no significant differences in the non-informative rates between invasive and non-invasive POC. Also that the cell-free DNA analysis correctly identified around 85% of samples. Sensitivity was 80% and specificity was 100%. And performing the cell-free DNA-based testing provides, again, a non-invasive approach to determine the genetic cause of the clinical miscarriage. So, in our opinion, if we obtain the products of conception, this is the way to go. So we have the POC, so we analyze it, and we get the results. But if we are not able to get them, then this is the way to go. We can give misoprostol to the patient, and prior to that, we will take the blood draw and provide the results. So, indications, recurrent miscarriage, every single case of early pregnancy loss, because we are analyzing from the 5th week of gestation. We already validated that we can obtain results. And also women who have undergone ART and have had a miscarriage. Even more, those patients without PGTA and embrace. Why? Because the patient is gonna get to your consultation and ask, doctor, why does this happen? Is there anything that I could do for my next cycle in order to try to avoid this? Well, we will know that depending on the age of the patient, we will have some embryos that will be euploid, some of them will be aneuploid, and then doing PGTA or embrace, we will transfer and recommend to the patient those ones that are having chances not only to get implant, but to have a healthy baby at home. And this is a concept because usually what we do is when we have a first miscarriage, we don't analyze it, but then we wait until the second one and we do analyze it. And let me put an example with these two patients where, again, first loss was not analyzed, and we analyzed the second one. And both of them were normal, euploid, talking about chromosomes. So then, should we recommend the ASRM workup? Probably yes. Patient 3, patient 4, again, first loss, we don't analyze it. The second one was aneuploid. So it looks like that maybe we can indicate PGTA for those patients. But here is the importance to have perspective. So I'm telling you that if we do analyze the first loss, we will have a better conditions in order to tell the couple what to do for the next cycle. Remember the first case, the patient 1, first loss, normal, second loss, normal. So then ASRM workup, because we do know that it's nothing to do with chromosomal abnormalities. Patient number 3, the second one was abnormal, but in this case, the first one, it's abnormal as well. So clearly, the indication would be perform PGTA. But what happened with the other 2 patients? If we analyze from the very beginning, both of them, we will find that either the first or the second miscarriage were due to chromosomal abnormalities. So then, do they have a recurrent risk for aneuploidy, or was it sporadic aneuploidy? So again, having the perspective, then we can do better counseling to our patients. Limitations, as every single test, we cannot detect polyploidies, such as triploidies, nor uniparental disomies, deletions or duplications under 7 megabases, then we cannot detect as well, and it's not possible to detect balanced chromosomal rearrangements. So just to conclude, I would say that in couples who have a miscarriage, it's very important to find out the reasons behind it. More than 50% of miscarriage in the first trimester are due to chromosomal abnormalities, and remember that it's up to 60% when the patients are undergoing assisted reproductive techniques. Almost 1/3 of patients are not able to get the true fetal tissue, and this is why doing a non-invasive POC, we can get results for them. And performing advanced non-invasive tests, which uses a blood test, will help us to determine whether a pregnancy loss was caused by a chromosomal abnormality. So say that, I would like to thank you, and if you have any question, please, go ahead. Yeah.
We have to do the test. Until how many weeks?
From 5th week up to the end of up to delivery.
36 weeks?
Yes. The important thing is to take the blood draw before the evacuation.
Do you think if by 5th week,
From the 5th week onwards.
by the 5th week you get adequate fetal DNA?
Yes.
So why NIPT we don't do in the first 5th
But
week?
this is something that we are working on, and we hypothesize that once the fetus stops,
Yeah.
then you have at the bloodstream more fetal DNA, and this is why we're able to go below in those gestational weeks.
So conclusion is this, कि after the fetal demise, more
After.
DNA goes to the bloodstream.
Probably yes, and this is something that we are looking for and
Oh,
doing the
great.
research. We don't know for sure yet,
Wow.
but could be a
That is
possibility,
the
yeah.
Would you still consider regular POC as the gold standard and then having an NIPOC as something additional that you can add?
Yeah, actually I would do that. If you have the pros of conception, then let's go analyze it. We do an NGS to know the status chromosomal of the fetus, and also STRs to discard or rule out maternal cell contamination or polyploidies. So I would do with this. But for other cases, then you can use a non-invasive POC.
This one from POC also and non-invasive test also. Both we have to do.
No.
Because it has not the specificity is 100%, but sensitivity is not
No.
much.
Uh-huh.
So
What we found is the concordance in between was 88% in between both of them.
So take home messages, we should go for non-invasive.
Okay, so thank you very much for your attention and have a good afternoon. Thank you.
Life. This marvelous reality that moves us in as many ways as there are people inhabiting this planet. The more we learn about it, its principles, its patterns, and its codes, the more we value being able to help people who cannot conceive naturally. iGenomics was founded in 2009 to work side by side with clinicians in IVF clinics to bring genomics to assist couples fulfill their dream of bringing healthy babies home. Since then, we have brought to light more than 500 scientific publications on reproductive health and processed millions of samples. At iGenomics, we believe that genetics should be available to everyone because important decisions deserve an accurate and personalized diagnosis. We want to accompany you on this exciting journey of life. iGenomics, with science on your side. This marvelous reality that moves us in as many ways as there are people inhabiting this planet. The more we learn about it, its principles, its patterns, and its codes, the more we value being able to help people who cannot conceive naturally. iGenomics was founded in 2009 to work side by side with clinicians in IVF clinics to bring genomics to assist couples fulfill their dream of bringing healthy babies home. Since then, we have brought to light more than 500 scientific publications on reproductive health and processed millions of samples. At iGenomics, we believe that genetics should be available to everyone because important decisions deserve an accurate and personalized diagnosis. We want to accompany you on this exciting journey of life. iGenomics, with science on your side.
Welcome back to our Vitrolife Group Academy Studio. We have the last session of the day, and it is my pleasure to introduce you, my friends and colleagues, Shannon and Angela. that I'm going to talk about biopsy and tubing best practices. So, Angela, Shannon, whenever you want, please.
Hi, I'm Shannon Kirkpatrick. I'm Senior Embryologist in Scientific Support with Vitrolife.
And I'm Angela Linville. I'm a Scientific Advisor with iGenomics. And today we'll be talking about best practices with tubing. So we'll break up the talk into two different parts. I'll first talk about the genetic testing portion and different types of no results, and Shannon will then take it over with the loading. So why is the loading procedure so important? Poor loading can lead to failed amplification and no results, requires rethawing, biopsy, refreeze, and causes additional stress of the embryo. Poor washing can lead also to contamination, and contamination can lead to a potential misdiagnosis. So there's two different types of no results, which can have different root causes. The first one is a no DNA detected, and the second is a non-informative. So for no DNA detected, this means that there was no DNA available for amplification, so we were not able to get any information at all from the sample that was sent to the testing lab. For non-informative, this means there was DNA amplified, yet the results failed QC. And this is typically because the DNA is not high enough quality for us to provide a result. So the different causes of these types of results, for no DNA detected, it's lack of nucleated cells, no cells in the tube, cells not properly placed correctly, must be at the bottom of the tube. If they're on the side of the tube, they can be missed and not amplified. If they're adhered to the side, it is not available for amplification, which can lead to a no DNA result. And then it can also be stuck in a bubble and not in the buffer itself, which also can inhibit or prevent us from amplifying cells. For non-informative, it can be if there's a large volume of buffer. This dilutes the enzymes, resulting in an insufficient RNA replication. The cells damaged during the biopsy or cell lysis can cause a non-informative. Poor quality cells or poor quality embryo. This is usually from DNA fragmentation, and also minimal or degraded DNA. So in most cases, we may never know the exact reason, but these give ideas to troubleshoot in your lab if you have if you have either one of these results. So a really important thing to consider when you are working with your PGT laboratory is to review the protocol, because every testing lab has different requirements. So they have different buffers, they can have different tubes, and also loading requirements, either dry or wet. It's very important that you follow the protocol from your laboratory to get the best results. And Shannon will then take it away with the loading.
Thanks, Angela. So let's start with some tips and tricks. Going back to our dish setup. So for biopsy, we want to set up our dish with small drops, maybe 10 to 20 microliter drops, one for each embryo to biopsy. We do want to be sure to label them appropriately, well labeled with patient information, as well as our embryo ID number. There are thousands of different ways to set up your biopsy dish, so follow your laboratory protocol. Just make sure your drops are not close enough where they're going to merge together. From there, we can add a PVP drop if we want to. We also want to make sure that we have various techniques of biopsy available to use. Every embryo is different, so every biopsy is different, and we may need to use different types of procedures or techniques depending upon each embryo. This may include our traditional kind of pulling, tearing technique, the old flick, which is the rubbing technique of the biopsy pipette on the hatching pipette. It may be the new flick or the tap, which has become everyone's favorite these days. And then seldom used, there is a technique using the oil droplet. So it's using the tension from the media drop and the oil to sever your cells from your embryo. What constitutes a good sample? We want to look for between 4 to 8 cells in our sample, and we do want to make sure that we see intact nuclei. So zoom in onto your sample, see that there are 2, maybe 3 intact nuclei that you can see before taking your sample, and that's what we're looking for. You do want to make sure to complete all of your documentation appropriately, both for your laboratory and for your testing laboratory. That makes things easier on everyone. Do set some KPIs. So this might be for each individual technician. Keep track of your no result rates, your non-informative rates, and this will help see if anyone deviates from protocol and may need some additional training. With your hood, you do want to start off with a nice clean hood. It should be disinfected. You can use a UV light if your hood has a UV light, but make sure you take things out of your hood before doing that. Acquire all of your tools and have them laid out in an organized fashion and have them ready for your tubing. Of course, you want to wear sterile gloves, a mask, hair cover. Label your tube appropriately. For iGenomics, this would be the patient's initials with the embryo number on both the top and the side of your PCR tube. You can either do preloading or dry loading. So what this means, you may take your biopsy sample and load it directly into your PCR tube, or you may preload the tube with maybe 2 to 3 microliters of your wash buffer all the way at the bottom. We do want to minimize the final volume of our sample, so do not preload with more than about 3 microliters, and best to stay as small as you can with that. But sometimes it does make it easier to have a preload sample or preload media within there. A microcentrifuge is a great thing to have on hand to drive that media down to the bottom of your PCR tube. Then we need to make sure to wash our cells. So 3 to 5 wash drops using our wash buffer will be set up into a dish. 1 row of wash drops per embryo biopsy sample. Do not go back into another row of wash drops with any particular sample and duplicate that. You do want to have an adequate size of wash buffer, so maybe 15 to 20 microliters per drop, not too small. And this will be performed at room temperature rather than at 37 degrees because we don't want to degrade any DNA now that it has been taken away from that embryo and it doesn't have that living structure that's supporting it anymore. Do go down to a smaller pipette tip when you're working with your biopsy sample versus what you would be using for your embryo. So a nice small pipette tip will help you keep control of that sample. And of course, change pipette tips between each sample. Don't reuse it for your next sample, even though it is the same patient. Washing is important because we want to remove any extraneous DNA, cellular debris, oil, any of those things. So we do want to gently wash the sample through every drop, maybe in and out several times through each drop, and then into the next drop, and so on until we get to our final drop and are ready to load. When loading, we can, again, do wet loading or dry loading. The important thing is we want to get that sample down to the bottom of that PCR tube. Of course, we can't really see into the bottom of the tube, so maybe just on the cusp, on that shoulder, is the easiest place to load where you can see your samples. But you do want to make sure that you visualize the cells entering the bottom of the tube. As soon as you visualize those cells, remove your pipette tip and don't expel the rest of the media. That will help keep that sample nice and small. A few things that we want to watch out for. Starting on the left, we don't want to load our sample on the wall of the PCR tube. As Angela mentioned, it can get stuck there and not get washed down into the bottom. We also do not want to have oil in with those cells. Oil can coat those cells and interfere with the PCR amplification process, and we may get a non-informative result. We also want to watch our volume. Remember to keep that total final volume under 5 microliters. Otherwise, our sample will get diluted, and again, we may have non-informative results. So nice small sample size at the bottom of the tube. That is what we're looking for, and a microcentrifuge comes in very handy at this time to make sure your sample is at the bottom. Wash, rinse, and repeat. So complete this process for all of your samples. When you are working with your tubes, do make sure they are well organized. So on the left-hand side is a good example versus on the right where we have just random placement of tubes. Have a spot where you have your unloaded PCR tubes and then move them to another spot, another row, once you have your samples loaded so that you remain organized. Freeze your samples as soon as possible once you're completed with your case. And you do want to make sure to leave your samples in the freezer for at least an hour before shipping them out. That way you can be really sure that they are frozen and stuck in place in your PCR tubes before sending them off for shipping. So in summary, always make sure to sample an adequate number of cells, again, approximately 4 to 8 cells. Rinse those cells sufficiently to make sure you're not carrying over any extraneous matter. Properly place it in the PCR tube at the bottom. Keep that volume to a minimum. And then finally, make sure it does spend adequate time in the freezer so that it doesn't get lost in shipping. Thank you so much. Good job, partner.
Great job.
Yay!
Life. This marvelous reality that moves us in as many ways as there are people inhabiting this planet. The more we learn about it, its principles, its patterns, and its codes, the more we value being able to help people who cannot conceive naturally. iGenomics was founded in 2009 to work side by side with clinicians and IVF clinics to bring genomics